In this video, we will walk you through everything you need to know about vasectomy, what it is, how it's done, what to expect, and how to talk to patients about it. Whether you are considering the procedure yourself or you're a clinician who wants to improve your counseling, this guide is for you. Let's talk about vasectomy. Vasectomy is one of the most reliable and widely available methods of permanent male contraception. In simple terms, it works by blocking or cutting the vas deferens, the tube that carries sperm. The procedure is usually done in outpatient setting and only requires local anesthesia. Before the procedure, it is important to have a thorough conversation with the patient. If you are a primary care provider, you should explain not just what vasectomy is, but also what it isn't. Patients need to understand this is a permanent decision. It's not something to consider lightly. You will want to cover alternative contraceptive options, make sure the patient understands those alternatives, and confirm that they are fully informed about the implications of sterility. This is also the time to discuss their relationship status, whether they are in stable partnership, how many children they have, and if they are planning for more in the future. Partner support can be a key part of decision-making process. Another point that's often overlooked is patients will still need to use contraception for at least 3 months after the procedure. But why? Because there is still viable sperm stored along the reproductive tract. Until that's cleared out and we confirm it with a semen analysis, pregnancy is still possible. And yes, while vasectomy is highly effective, it is not 100% guarantee. There is a small but real failure rate, roughly 1 in 2,000. Also important that vasectomy doesn't protect against sexually transmitted infections. So unless the patient is in a committed monogamous relationship, condom use should continue. Before moving forward, take a good medical and surgical history. Look for any abnormalities in sexual development or previous injuries or surgeries involving the genitals. On physical exam, confirm there is 1 testicle and 1 vas deferens on each side, and make sure there are no significant anatomic abnormalities. If anything unclear, for example a solitary testicle, prior extensive surgery or non-palpable vas, should be evaluated by a urologist. Contraindications to vasectomy include the presence of scrotal hematoma, genitourinary or groin infection, and sperm granuloma, but the procedure can often be performed if those issues can be resolved. Bleeding diathesis or presence of local anatomic abnormalities such as varicocele, hydrocele, scrotal mass, and cryptorchism should be referred to a urologist instead of having a vasectomy done in a regular doctor office. Routine preoperative laboratory tests, prophylactic antibiotics, and fasting are unnecessary. The patient should not drive immediately after the procedure and therefore should arrange transportation home. One practical tip: advise the patient to stop taking aspirin and non-steroidal anti-inflammatory medications about a week beforehand to reduce the risk of bleeding. If the patient is anxious, an oral anxiolytic like diazepam, 10 mg orally, may be helpful an hour before the procedure, but always get consent first. It also helps relax the cremasteric muscle and make it easier to isolate the vas. Topical anesthetic creams like Emla, a mix of lidocaine and prilocaine in 2.5%, can also reduce the sting of anesthetic injection. It should be applied to the front of the scrotum about an hour before and cover it with plastic wrap to help it absorb properly. But dosing is weight dependent, and systemic toxicity like methylglobulinemia is unlikely if Emla cream is applied correctly. The knowledge of surgical anatomy will help ensure safe, efficient, and effective vasectomy. The anterior scrotal skin and spermatic cord are innervated by branches of ilioinguinal and genital branches of the genital femoral nerve. Blocking those provides sufficient anesthesia. Just under the skin, we encounter a layer like the dartos fascia and muscle, the external spermatic fascia, and the cremasteric fascia and muscle. Then the internal spermatic fascia covers the spermatic cord, which contains the vas deferens and neurovascular supply to the ipsilateral testis. The spermatic cord also contains the deferential artery of the vas deferens, and the pumpiform plexus. The pumpiform plexus consists of 8 to 10 veins that lie adjacent to the vas deferens and ultimately drain into the testicular vein. Those veins are easily injured during aggressive dissection of the spermatic cord. Dilation of the pumpiform plexus or varicocele is a common abnormality and usually occurs on the left. A varicocele can make isolation of the vas deferens more difficult. You can watch how to manage varicocele on my channel. The procedure takes approximately 15 minutes and can be performed in an appropriately equipped office or ambulatory surgery center. There are two main techniques. Conventional vasectomy. This traditional vasectomy approach involves bilateral scrotal incision through which each vas deferens is mobilized and transected. It is less common in the United States, but still standard in many parts of the world. The second one is no-scalpel vasectomy. This technique is developed in China, and this approach uses puncture instead of an incision. A sharp instrument creates a small opening just wide enough to externalize the vas. The rest of the procedure is the same. Studies shows no difference in effectiveness, but the no-scalpel method tends to have less bleeding, fewer infections, and less postoperative pain, which is why it is preferred technique in the United States. The equipment needed to perform a vasectomy includes antiseptic like povidone iodine or chlorhexidine to clean the scrotal skin, sterile gloves, drapes and gauze, electrocautery or thermal cautery, absorbable sutures like chromic or vicryl, preferably on a non-cuttle needle, local anesthetic, typically lidocaine 1 to 2% without epinephrine, maximum dose 4.5 mg per kilogram, 10 ml syringe with a fine gauge needle, and surgical instruments like vas fixation clamp, sharp dissecting forceps, straight scissors, and needle holder. In position, the patient is asked to lie supine on the procedure table. It is helpful to position and secure the penis onto the lower abdomen with surgical drape, adhesive tape, or umbilical tape. Hair is shaved from the anterior scrotum, which is then prepared with the anesthetic solution. Sterile towels are placed around the scrotum, and sterile technique is employed for the remainder of the procedure. Using the free-finger technique, isolate the vas as superficially as possible the median rough of the scrotal skin anteriorly, midway between the top of the testis and the base of the penis. Inject a small vial of local anesthetic over the vas. Then, with tension on the vas, the needle is advanced through the anesthetized scrotal skin approximately 2 to 3 cm along the shed of the vas, but not into the vas, towards the inguinal ring, and 2 to 5 ml of anesthetic, depending on concentration, is injected into the tissue surrounding the vas. Some operators then anesthetize the contralateral vas to give the medicine enough time to take effect. Alternatively, some clinicians use no-needle jet injectors, which spray anesthetic directly through the skin. Once anesthetized, trap the vas with a fixation clamp. For the conventional method, make a small, less than 1 cm incision. For the no-scalpel technique, a sharp mosquito hemostat used to puncture through the scrotal skin to create an opening approximately twice the width of the vas by gently spreading with both tips of the hemostat. If a vas fixation clamp isn't in place, it can be left alone or repositioned as needed. If the vas has not been fixed in a clamp, it should not be grasped. The was is elevated through the incision or opening with the Alice clamp, towel clamp, or dissecting forceps. The perivasal tissue is dissected and separated using a dissecting hemostat. Then, approximately 2 cm of the was are brought up as a loop, gently engrafts with a second was fixation clamp, towel clip, or ring forceps. The loop of was is cleaned of residual tissue with care to avoid trauma to associated blood vessels. Gauze can be used to achieve blunt dissection. Alternatively, the tip of the hemostat or tips of the dissecting forceps can be inserted into the window of the was deferens loop and gently spread to completely isolate the was. Next step is wasal division. Then the was is divided and a segment of was is removed, also the minimum length of was that needed to be removed to prevent recanalization is controversial. Rates of recanalization more likely reflect the technique used to manage the wasal end than the actual length of the segment removed. We favor excision of a segment 10 to 15 mm in length. The optimal method of managing the testicular wasal end is debated. There is no universal agreement on the best approach, but most experts agree that simply trying off the end with sutures or clip isn't ideal. Instead, the most effective technique appears to be intraluminal fulguration of the prostatic end, basically cauterizing the inside of the tube combined with facial interposition. Then we place a piece of surrounding tissue between the two ends to physically separate them and reduce the chances of reconnection. Fulguration using a battery-powered hand-read cautery, red hot wire, seems to produce better occlusion than traditional electrocautery. It creates a more reliable seal by scaring the lumen shut. For the facial interposition part, we use either an absorbable sutures or a clip to pull a layer of the was shed between the two ends. This adds an extra barrier, and study shows it helps lower the failure rate even further. On the flip side, relying on ligation alone, that is just cutting and tying of the was, is associated with higher failure rate. A review of 6 studies reported failure rates ranging from 1% to 6% then this method was used. The problem is that the tie ends can break down over time, potentially allowing the was to rejoin and sperm to get through. Traditional medical practice recommends occlude both ends during a vasectomy by fulguration, ligation, or clips. However, some experts prefer a different approach called open-ended vasectomy, where one end is left open. The idea here is to let sperm leak out, which reduce pressure buildup in the epididymis and may prevent rupture of the formation of painful granulomas. One large study comparing over 8,000 vasectomies found that the open-ended approach actually results in fewer complications. It showed lower rates of epididymal swelling, 1.2% versus 2.7%, and sperm granulomas, 1.5% versus 3.2%, compared to the traditional methods. Importantly, both techniques were equally effective at preventing pregnancy with very low failure rates. After ensuring hemostasis, return tissue to the scrotum. If you made an incision, close it with absorbable sutures. No closure is needed for the no-scalpel approach, but skin glue isn't an option. After finishing, apply antibiotic ointment and cover with a bandage. Add soft padding and help the patient put on tight-fitting underwear or scrotal support. In postoperative care, the dressing and scrotal support are maintained for at least 48 hours after surgery. Intermittent ice pack for 24 to 48 hours helps reduce pain and swelling. Some discomfort is expected and typically resolves in a few days. Non-steroidal anti-inflammatory medication like ibuprofen are usually enough. Mild pain, swelling, and bruising are normal for the first 2 to 3 days. The patient should call for increasing pain, bleeding from the incision site, fever, or significant scrotal swelling. Activity should be limited for 24 hours. Light work is okay after 2 to 3 days, but no heavy lifting or sports for at least a week. Sexual activity is avoided for 1 week. The patient and his partner should be reminded to use an alternative methods of contraception until semen analysis have confirmed absence of sperm or azoospermia in the ejaculate. Since sperm are stored along the entire vas deferens and in the seminal vesicle, interruption of the vas does not result in immediate sterility. After a vasectomy, patients need to get their semen analysis 3 months after the procedure and only after at least 20 ejaculations. Most men will be azoospermic by then. More frequent ejaculation can speed that up. Older age tends to slow it down. A systematic review including 56 studies reported the time to achieve azoospermia was variable, but more than 80% of men were azoospermic after 3 months and 20 ejaculation. The time to achieve azoospermia declines with increasing number of ejaculation following vasectomy and increases with patient age. If there are motile sperm at 3 months checkup, a follow-up test is performed in another 1 to 2 months. Vasectomy is considered a failure if motile sperm are confirmed on the follow-up examination, there have been a sufficient number of ejaculation, more than 20, and more than 3 months have elapsed since the procedure. The patient should be advised to use alternative contraception and potentially undergo a repeat procedure. Azoospermia is the ideal endpoint of vasectomy. A small portion of patients, however, do not achieve azoospermia but consistently have non-motile sperm. Non-motility is a less definable sign of infertility than azoospermia, since it may reflect death of recently motile sperm due to a prolonged delay between ejaculation and laboratory test. The accuracy of determining whether sperm have normal motility is dependent on the timely examination of the semen specimen, ideally less than 4 hours from the time collected by the patient. Then rare non-motile sperm are observed, a repeat test in another 1 to 2 months may show azoospermia or continued presence of rare non-motile sperm. If a man have a very small number of non-motile sperm after vasectomy, it is probably clinically insignificant, and those men can be given cautious assurance of success. 2 major medical organizations provide guidelines about when it's safe to stop using other methods of contraception. The British Andrology Society says it's okay to stop using other methods of contraception if the sperm count is very low, less than 10,000 per milliliter, all sperm are non-moving, it's been at least 7 months since the vasectomy, and the man has ejaculated at least 24 times. The American Urological Association has similar rules. They say it's safe to stop using other birth control then a fresh semen test shows either no sperm at all or only rare non-motile sperm, defined as presence of less than 100,000 non-motile sperm per milliliter based on microscopic exam of at least 50 high-powered fields. Complications following vasectomy includes hematoma, infection, sperm granuloma, and persistent post-vasectomy pain. The first one is hematoma. Bleeding and/or hematoma formation is the most common complication associated with vasectomy. In rare cases, bleeding may be severe enough to require reoperation for scrotal exploration, hematoma evacuation, and control of bleeding. The most common site of bleeding is pumpiform plexus of vein. The sperm granuloma is a small inflammatory lump near the vas cut site. Sperm are highly antigenic and stimulate a significant inflammatory reaction. A sperm granuloma may form when the sperm leaks from the testicular site of an open-ended vas following vasectomy. Less commonly, they may form with extravasation from a cauterine or fulgurated vas. Those granulomas are rarely symptomatic and may be protective to the testis and epididymis. The granuloma is rich in epithelial lined channels that may vent leaking sperm away from the epididymis and protects against increasing intraepididymal pressure. Most granulomas are asymptomatic and over time will ultimately resorb. Granulomas, however, have been implicated in increased rates of post-vasectomy pain and in worse recanalization related to the inflammatory response induced by the antigenic reaction to sperm. Patients with an acute symptomatic granuloma typically present 2 to 3 weeks after vasectomy after they have resumed sexual activity. Most patients respond to supportive care including non-steroidal anti-inflammatory drugs. The post-vasectomy pain syndrome is different from the normal pain you feel right after the procedure. Early studies used to suggest that long-term pain was extremely rare, affecting less than 1% of men. But more recent surveys data tell a different story. Around 50% of men report some form of ongoing, bothersome pain after vasectomy, and about 2% experience pain that's significant enough to interfere with their daily lives. That said, we should take those numbers with some caution. Survey-based data don't always reflect the broader population. In most cases, post-vasectomy pain comes from chronic conjunctive epididymitis. After vasectomy, the testes continue to produce sperm and fluid, but now that the outflow is blocked, this material backs up in the epididymis. In some men, this causes swelling and chronic, dull ache that tends to worsen with ejaculation. Other causes of contributors to pain syndromes include the formation of sperm granuloma or nerve entrapment of the vasectomy site. Management usually starts conservatively. First-line treatment includes non-steroidal anti-inflammatory drugs and warm baths, which are often enough for mild symptoms. If that doesn't help, nerve block or steroid injection may be performed. Then symptoms persist despite those measures. We move to surgical options. One is vasectomy reversal or vasectomy, which can relieve pain in about 70 to 82% of well-selected patients. Those patients, however, will almost always require the use of another form of contraception as a result. In most severe cases, a complete epididymaectomy, surgical removal of the epididymis, may be considered. But this is a last resort. There is a risk of damaging the testicular blood supply, which can lead to testicular atrophy, and unfortunately, 30 to 80% of patients who undergo epididymaectomy still report residual scrotal pain afterwards. While vasectomy is meant to be permanent, life changes and reversal is possible. Vasectomy can be resolved with microsurgical techniques. Vasectomy reversal involves reanastomosis or vasectomy of the vas deferens, ideally at the site of the previous ligation. Successful vasectomy reversal have been reported in 50 to 70% of men. Rates declines with increasing time between vasectomy and reversal.
So that's it for today. I hope this video helped you understand this topic better. If you find it useful, don't forget to like, subscribe and hit the notification bell so you don't miss the future videos. Let me know in the comment below what you think or if you have any questions. Also, don't forget to follow me on Instagram for more useful educational posts. Thank you for watching and I'll see you in the next one.